Hello, and welcome to Visionary Medicine, the next era of retinal disease treatment and patient adherence. Thank you so much for joining us. I'm your moderator, Rachel Deere with DKB Med. And here are our esteemed faculty, Dr. Joseph Coney from Case Western Reserve University, and Dr. Grayson Armstrong from Massachusetts Eye and Ear Harvard Medical School. Dr. Coney, Dr. Armstrong, thank you so much for being here.
Thanks for having me.
It's such a pleasure.
And here are our faculty disclosures. This activity is supported by educational grants from Genentech and Regeneron Pharmaceuticals, Inc. All activity content and materials have been developed solely by the planning committee members and faculty presenters. This accredited activity is jointly provided by Partners for Advancing Clinical Education, or Partners, and DKB Med. Partners designates this enduring activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. In support of improving patient care, this activity has been planned and implemented by Partners for Advancing Clinical Education, Partners, and DKB Med. Partners is jointly accredited by the Accreditation Council for Continuing Medical Education, ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. And here are our learning objectives. Describe consequences of delayed and interrupted care for RVO, and assess the efficacy of newer treatments for RVO. Thank you so much, and I will now turn things over to Dr. Coney.
Dr. Armstrong, before we get into today's discussion about burden of disease and barriers to adherence to care when it particularly to retinal vein occlusions, I want to hear from our two patients and understand their journeys a little better.
Yeah, absolutely. I think it's so unique that we get the opportunity to hear from our patients today. So let's kick it off.
Well, when I was first diagnosed, I was having problems with my right eye. It kept feeling like something was in it and it was feeling blurry. So I went to a clinic and they referred me to the Retina Association where I'd seen the doctor there.
When I was in Bloomington, I would get an eye injection and I would be out literally for a day.
Honestly, I was like very nervous and uncomfortable because one, I don't like needles. But he told me, it's a chance that I could go blind. And he also gave me, some time to think about it. So I went back home, a few days I was thinking, I said, well, I don't want to go blind, but I don't want to get the needle in my eye either, because that just didn't seem normal.
The injection site would be excruciating because of I guess the betadine that they would put in there that would just irritate the eye.
I decided to go ahead and take a chance, with the trial. I had never been in one. I've heard about it, but I've never experienced it myself.
They were giving me a different injection that really didn't work. And I was getting these injections in Bloomington probably, I want to say every month, and it did very little. They may work for about 2 weeks, and then my sight would be blurry. So, um, very little success when I was in Bloomington, to be honest with you, plus the irritation.
I took a day off from work because I couldn't drive. They had a driver come and pick me up from home and bring me back.
When he saw that there was little to zero improvement, he said, "Hey, let's change the medication to a different one." And that one was almost like day and night. My vision cleared up, and it lasted for about 4 or 5 weeks. Then we stretched it out to 6 weeks. It totally increases your quality of life around planning because when it's every 4 weeks, it's kind of hard really to plan trips and everything because like, oh, I got a doctor appointment, really can't miss it. And so being 6 weeks out, it really gives you that freedom to say, you know what, I can go a month and a half, and not have to worry about, as my wife said, get stabbed in the eye.
Even though I was getting the injections each month when I went, it was still knowing I got to get that needle in my eye. It was, it wasn't nothing I was like really comfortable with.
For the last 2 years, I would say I go in, get the eye injections, especially now with the new solution they put in your eye or eye drops before the injection. I'm back at work within 30 minutes with very, very little irritation.
I want to thank our patients for their testimonies. It was really helpful. Both of those patients are my patients, and so I understand the burden that they really go through. And I should have brought it up, but I didn't. So the young lady that was in that you interviewed, she was originally one of our. She was in the I think the aflibercept arm for RVOs. And when I spoke to her and as a new patient, I gave her the option of a trial, and she was like she was all gun ho. And then she talked to my study coordinator, and then she didn't want to be in the trial. And normally, if that happens, we'll just go ahead and treat and keep going. But I went back into the room that day when she came back just for starter therapy, and had a heart-to-heart conversation on really what her apprehensions were about being in a clinical trial. 90% of the trial data we have is from European ancestry. And I let her know that, the reason I want her to be in the trial is because she was Black and we don't have good representation. And then we went into what her apprehensions were, and we had a great discussion, and she decided to be in a trial. She's one of those people that went from 2400 to like 2020. And then she enrolled in the extension trial. And although she was still fearful the whole time, there's one thing that being in a clinical trial can help. It gives them the same. I think just by seeing that clinical team always got somebody you can call on, it really decreases the apprehension of patients. And I think that for us as clinicians, we need to be tuned in to different populations of people and know how to talk to those individuals, discuss those barriers, so we can increase the representation in the trials.
I totally agree.
Um, Dr. Armstrong, this slide here, when it talks about clinical trials and real world data, is something that I've seen so many times, and it's something that we all kind of grapple with. When we look at clinical trials, 90% of these individuals are able to retain vision, particularly in the earlier years, compared to what we see in the real world. Can you shed some light on why you think this is?
Well, I think we heard a lot of it from our patients, right? So your patients are very upfront about the fact that there's a lot of fear and a lot of anxiety about coming into the office. And they face a lot of barriers like driving into the office or being unable to drive after their injections. They're having frustrations with their treatment burden. They're having frustrations with not seeing better after they've tried multiple shots in a row. So perhaps if they're not enrolled in a clinical trial, it's not surprising that they drop out of care. Perhaps they delay their care. And then, of course, that results in visual failure, right? These are patients that otherwise it's frustrating, they're scared. And, we know if they can stick with the treatments and we can get them optimized, we can get their vision better in most cases, but there's a lot of barriers there.
Yeah, I agree. And I don't think this is just true to RVO. I think that in the earlier segments, we talked about DME, we talked about AMD. Both of those individuals, whether real world and clinical trials, it was very similar. I think across all of our disease states, we're just not getting the impact in the real world that we see in clinical trials. There's some great literature that was done recently by Michael Epps, who looks at RVO in terms of those patients being adhered to therapy. And in the first year, they received about 7 injections, and about a year 5, those injections had gone down significantly. A lot of those patients were actually lost to follow up, and those individuals that stopped therapy also had worse vision. What is your impression of requiring multiple injections and trying to maximize vision?
Yeah, these barriers are true across all the disease states, and I think that it's really challenging to try to keep these patients adherent to care because of these barriers, right? Your patients highlighted it well. They don't like a needle. They don't want to come in. If they have to come in, they will, and especially if they don't want to go blind. But, clinical trials are not the real world, and the better we can do to alleviate those burdens, whether it's through our own education, whether it's through our demeanor and trying to create a relaxing environment, or maybe it's through these new therapies that we'll talk about today, I think that we can start to get closer to what those trials are showing.
So when we talk about retinal vein occlusions, we know that this is the second cause of vision loss in the real world. And I look at this as the stepchild in things that we treat. Most of our data is surrounded around AMD and DME. And the drugs that we get approved are later approved for retinal vein occlusions. And I don't think we really have a total grasp on the prevalence of this particular disease. We do understand why people lose vision. The most common reason why they lose vision is cystoid macular edema, as well as ischemic changes. We do understand that BRVOs is much more common than CRVOs. And then there's risk factors I think that we all should be aware of. Older patients typically don't do as well. They typically have high blood pressure, diabetes, peripheral vascular disease. And I think, I think glaucoma is one of those things that are probably least understood, but because CRVOs, it happens at the lamina curvosa, this is much more common in those individuals. When I look at the comorbid problems that exist when it comes to retinal vein occlusions, I'm always thinking about populations that may be at more risk.
It's interesting because if you look at these risk factors, aside from glaucoma, a lot of these are the same types of risk factors you might see for diabetic retinopathy. And these are patients that have systemic illnesses that may or may not be totally well managed. And the less well managed they are, the more likely they're going to sit in your seat as a result of either a BRVO or a CRVO. And so they're already coming in with challenges accessing the system or lapse of follow-up of some kind for their systemic illness is my take. And they're more likely to also miss visits down the road because they're going to be hospitalized for some certain diseases. But there's also the subset that didn't realize they maybe had hypertension or cholesterol issues, and then they're sitting in your seat and you can help kind of coach them through these systemic issues that are really the cause of this ocular complaint. But generally, I think that these are motivated patients to try to get their vision better if they can, because the CME that they end up with is very visually debilitating. The problem that I've seen in these patients is that while they've been hesitant to access care for their systemic disease, they're very quick to they want quick results for their eye disease too. But unfortunately, this is a really persistent, troublesome visual problem, and it can be very, very tenuous in terms of the need for treatment.
Yeah, and when you look at the prevalence of this disease, I think that this is where we probably don't have a great handle. A lot of the data shows that there's no differences in Black and Hispanic patients compared to whites. But then when you look at some of the overall data, you can see that Black, Hispanic, and Asians may have a higher prevalence to retinal vein occlusions compared to their white counterparts. Julia Haller did a great review on papers looking at disparities in retinal vein occlusions and the presentation and treatment initiation. And nearly 60% of these eyes require therapy. She found that those eyes that had really good vision or really poor vision had less injections. What really struck me is that Hispanics and Blacks typically had less injections than their white counterparts, but they presented with worse vision. What was your take on Dr. Haller's paper?
I think the big thing that I took away from this is that the different ethnicities probably have different risk factors at baseline in terms of their socioeconomic status. And so it might have caused some delays in getting in terms of accessing the care, a different level of anxiety, different financial barriers there. But, generally, it makes sense that if they have better vision at the beginning, that they have less injections. I found it very interesting that the worse it was, less injections sometimes too.
Dr. Armstrong, I completely agree. Those individuals that have poor vision, which is about 40% of patients, oftentimes these eyes would develop neovascular glaucoma. These occur typically in more advanced individuals like Black and Hispanics. And it's probably true that when they come in, they probably have more ischemic areas, so they probably don't require therapy. But also, I look at these eyes as eyes I'm trying to save. Oftentimes, I do add in therapy because I'm concerned about a blind, painful eye. But it's very interesting on the disparities that we see based on a patient's presentations and also based on their comorbid problems. Some of the characteristics that they found with CRVOs in a retrospective review, Blacks presented at a worse visual baseline compared to whites, but there was no difference in the visual outcomes at the end. When you're seeing patients in your clinic, do you see a different response in different populations of people?
I think that generally the way that this disease tends to work is it's very VEGF sensitive. And so I think that they are all responding quite well. And it's interesting they show up with different baseline vision. I agree. But luckily, all these patients tend to respond well and they can end up with similar results just like this. I think this rings true for my patients.
Yeah, I also think that people present, worse because of barriers to care. You're at Mass Pioneer, and in Boston, I know that there was something that Mass General had done with Beth Israel, where they were looking and trying to unfold those individuals that had higher social determinants of health in their medical records. And so when patients come in, they would have these questionnaires that was not threatening to see if patients required any additional help, and that was based on travel, based on socioeconomic status, based on education, and they were trying to see how they can trigger, well, how they could put certain resources in certain populations so they can adhere to their therapy. In the eye clinic, are there any? Have you guys adopted any of these initiatives to better understand the population that you serve?
Yeah, we have, and we're lucky to have that level of granular detail about their socioeconomic barriers in our charts. Not every patient answers these questionnaires, so it's purely based on people that have that. But for example, not with retinal vein occlusion specifically, but for diabetes, we do look at these risk factors and see what we can do to overcome, whether that's travel, they need an Uber gift card, for example, or whether they need childcare provided for them for the day, or they just need time away from their work, and giving them a work note sometimes is all they really need. But this is something we're actively looking at in that population. And we don't have it for RVOs, but we do have AI cameras that can detect diabetic retinopathy. And so I think in the future, multiple diseases will come down the pipe. And we're really trying to target these underserved populations where it's hard for them to access eye care. And so if we can really meet them where they are instead of forcing them to come to our offices, for example, if we can understand their barriers and try to overcome them so that they don't have these systemic issues in their their home life, in their financial life, I think that it will make a big difference. So yeah, I agree. We're lucky to have that data.
Well, that's really great, because I think one of the biggest things that we see is really not adherence. Patients keeping their appointments when they need to, because we know when they fall off their injections, they typically don't do as well. One study found that up to 30% of individuals will be non-persistent to having their therapy. There was a review that looked at over 3,000 patients, and they found that 25% of individuals were lost to follow-up 12 months after their original injection. And they found that this was much higher in Black and Hispanic populations. And depending on where they live, if they live 20 miles from a clinic, these patients tend to fall off. They also found that 26% of patients with retinal vein occlusions did not have care at 12 months after diagnosis, and 44% after 2 years. Can you speak to the impact that missing clinic or not being adhered to a certain regimen? What effects can that have on visual acuity long term?
Well, for these patients specifically, this issue is so important. The loss to follow-up really does lead to vision loss in these patients because, like I was talking about before, in my opinion, retinal vein occlusion is kind of this thing that's very responsive in the short term to VEGF injections. But the moment they pass that 4, 5, 6 week, 8 week mark, whatever it is for them, it comes back in force and their vision drops. And we've seen before that their vision doesn't always come back to baseline. I think we're going to get to that in a second. So the better we can keep these people in treatment, the better their vision is going to be long term. And I think the better they're going to prevent neovascular complications as well.
Yeah, absolutely. I think you were really speaking about Dr. Morent's paper, where they did a retrospective review of 64 patients that deferred therapy. And by that, they meant, delayed more than 10 weeks. They found that the visual acuity returned to baseline after 6 months. It was no different at 2 years, but there was still an impact on their vision long term. And even when people fall off, we're able to restore their OCT, but yet their visual acuity can be significantly affected.
And really, the other thing about that is that for the Salabiti study, where they looked at patients that had longer term loss to follow-up, it wasn't that 10 weeks, it was more like 39 weeks in some cases. These patients did worse in terms of returning to baseline. So I think that there is a time component here where shorter loss to follow-up, you can overcome that. But longer loss to follow-up, by the time they come back, sometimes that retina's already been so swollen for so long and so much disruption, it doesn't always get back to where it was before.
Absolutely agree with you. And we really saw this in the Bravo trial. The Bravo trial was a well-constructed trial. It was a randomized a treatment trial. Those individuals that received ranibizumab 0.3 milligrams or 0.5 milligrams to sham over 6 months. And at that 6 months, the individuals that were randomized to sham was actually crossed over. When they were crossed over, they did have vision gains, but they never really caught up to those eyes that were treated earlier, despite even having significant improvements on the OCT. What I also found interesting about Bravo is that in the treatment arms, once they got to month 6, they were actually at a PRN dosing. And you can see that there's a slight decrease in the vision and increase in the OCT just by delaying therapy for a month. There was an impact on some of these patients. You know, we've made great success with our first generation of FDA approved drugs, from aflibercept to ranibizumab to even off-label use of bevacizumab. I'm really wanting to get your thoughts on the second generation of anti-VEGFs and how this plays a role in your patients.
Absolutely. We're so lucky to have new treatments coming on the market that we get to use in our office for our patients. And really, at the time we're recording, we have a brand new one just a couple days ago. And so it's constantly evolving. And I'm really excited to talk about the changing landscape for anti-VEGF therapy for these patients. But first, why don't we hear from your patients and see how they experience this and how they hope for innovation too?
If I could change anything, I would say this. If they could come up with an eye drop without the injection, because I don't know which is worse, the thought of a needle piercing your eye and the anticipation of it, because there's nothing you really can do other than, breathe.
Well, if I had my choice, it probably would have been an eye drop or a pill.
If they come up with an eye drop, that would be totally magnificent. Or if we could get to the place where it's once a quarter or twice a year, even once a year. Oh man, that would just be uh, terrific. But as it is now, 6 weeks is durable. You learn how to plan around those visits.
I feel like, okay, the doctor who's ever given the injection, they should, if the person is nervous, making them feel really comfortable and at ease, that helps a lot.
What I would say to any healthcare practitioner when it comes to RVO or any type of issues that a patient is dealing with, the first thing is ask them how they are doing and if they're dealing with any type of anxiety, because that is probably the biggest issue that I dealt with was, okay, is this eye injection going to work? What are they putting in my eye? Is it a one and done? Is it so there's a lot of questions, and sometimes you may not even know what to ask.
Well, if it's somebody who's like has a fear of needles, I guess they have to let them know the importance of it, and what could happen if you didn't get it done. But talk to them in a way where they're comfortable and relaxed, but they know the doctor is serious about what he's saying.
And so having a healthcare provider or a specialist that takes the time to say, hey, first of all, you may be feeling a little, anxiety. That's normal. Take a couple of deep breaths. And how are you feeling? And this is what's going to happen. You may feel a little pinch, but trust me, you'll be okay. All right. Um, that is the sort of, I think, information that a patient really needs to hear, that is going to be okay, to put that patient at ease as much as possible. And then afterwards to say, do you have any questions for me? Anything I can answer?
Yeah, your patients put it so eloquently. They have a lot of hope because, if they can get away from needles in general, I think that it's a win for everybody in terms of the fear and anxiety. But we're not there today, right? We unfortunately do require injections in the eye, but we have new therapies on the market that have been proven to have benefit in retinal vein occlusion patients. So I think that now I get the pleasure of kind of talking about this, and I'd love to your thoughts, Dr. Coney, on these new therapies. Aflibercept 8 milligrams was just recently approved by the FDA for use in retinal vein occlusion, and faricimab has also had a longer standing but still approved for FDA use. So there was the Balaton and Camino trial for faricimab, and what you see in this trial is that for the first really 6 injections, they had Q4 week injections of faricimab 6 milligrams as compared to aflibercept 2 milligrams. And after that, they went into this kind of treat and extend model. But really, that first 6 months is critical for this study. If you look at the data, the outcomes of this, they had non-inferior results in terms of visual acuity outcomes, as well as the retinal thickness. And so, is this something that you've seen in your office with faricimab?
Absolutely, and it's not just in retinal vein occlusions, but also it's been across disease states. And in the trial, you even saw that at the end of 24 weeks, there was a significant reduction in the absence of angiographic leakage just in a short period of time. I'm interested to see what your
Yeah.
thoughts is. This first 6 months was great. I mean, they were both. It was a head-to-head trial, but there's this burden is much longer than 6 months. So what's been your impression of eyes that goes longer than 6 months?
I mean, there's data, right? So we just talked about the Bravo trial. It shows that if you take them from a Q4 week treatment, of course, that's not faricimab, but the moment you change that interval and you try to either go to PRN or stop dosing them, there are some patients that get worse. So 6 months is not enough. This is a long-term game, and we know that in the short term, we want to get rid of the CME. In the long term, we want to maintain good vision and also prevent neovascular complications. So 6 months is really just the tip of the iceberg for these people. I'm also impressed at the level of absence of macular leakage in these people, whether it's fluorescein angiogram or OCT. But in my opinion, I've found that faricimab is incredibly helpful for these patients. And so I think these trials for both BRVO and CRVO ring true for me.
Yeah, I think it really just talks to the effect of the bispecific molecule, which actually not just VEGF but also Ang2. The Ang2 is doing something different than we've seen before in these individuals that were just getting anti-VEGF.
Yeah, stabilization of those retinal vessels is really key with the Ang2, and so this bispecific molecule I think is doing something that we weren't seeing before, and we see it in the data. More closer to my practice, I think that we all try to decrease the burdens, like your patients were talking about, by going towards different methods of treating these people by treat and extend. And so there was in this Balaton and Camino after the 24 weeks, a treat and extend version. You can see here on this slide that it was purely based on their vision and based on the thickness of the retina. If their retinal thickness wasn't getting worse and their vision was at least stable, if not improving, then they were able to extend beyond that 4-week treatment arm. And with the results there, you can see off into these, even up to 72 weeks, they had incredible results in terms of vision. They had incredible results in terms of retinal thickness. And this speaks directly to what you were talking about, Dr. Coney. Like, we don't have 6 months and then it's over. This is really a long-term relationship with our patients. We really need to be there to coach them that this is going to take some time. If they're lucky, they can spend less time in our office with us, but they can maintain their vision.
Yeah, absolutely. I think that also with the second generation of biologics, particularly here with faricimab, we can see that at week 72, those eyes that lost more than 15 letters, I mean, there was very little individuals. I mean, you get a reassurance that patients can do well. And this is really important because, as you said before, there's barriers to therapy in the real world. Things happen. These are sick individuals. They will miss appointments, but with longer drug delivery, we're able to see less fluctuations. And those individuals that had those initial visual gains tend to keep those visual gains out to 72 weeks.
Yeah, there was a slight difference, of course, between BRVOs and CRVOs here. I think that the pathology being a little bit different and more aggressive in CRVOs, maybe it didn't have quite as good of outcomes, but it's really promising to see that, a lot of these people gained over 15 letters. A lot of people avoided loss of 15 letters. It's really incredible. So this is really reassuring data. If you look again all the way out to 72 weeks, the central subfield thickness reduction is impressive in both arms. So I think this really does just go to show that we're going to hopefully be able to find regimens that are unique and specific to each patient moving forward. And I'll also just point out for the CRVO arm here in Camino, the moment you switch to a treat and extend type model, it does have more likely rebound and worsening of the central retinal thickness. But over time, this balances out and you can get that back by finding the customized treatment for them. And I don't know that in your practice you're extending people by 4 weeks at a time. Dr. Coney, is that what you do?
So, this was something hard for me. I was probably a slow adopter. Initially, I tried patients that were more high flyers. And so I was very reluctant to extend those patients out more than 2 weeks at a time. But once I got more comfortable with the medication, particularly in my naive patients, if they were dry after the induction therapy, then I felt more comfortable in extending these individuals out a month at a time. And so what I've adopted now is that particularly if they're naive and they do well, they extend it 1 month at a time. And if they've been treated for a number of times, I will basically load them at the place where the fluid reoccurs, and then I would try to extend after that. So that's something I've adopted into my clinic, and I try to provide a customized way of therapy to limit the burden of therapy in order to maximize their vision.
Yeah, I think that makes sense. I'm a little bit more hesitant. I don't go straight to 4 weeks all the time. In the right patient, I agree. But I have found that this disease state compared to other retinal diseases is a little bit more aggressive sometimes, especially the CRVOs. So, 1 or 2 weeks at a time for a CRVO makes more sense in my hands. But I'm glad to hear that it's possible. Maybe I should get a little more, a little more brave.
Well, I do think we have some data that look at 68 weeks in both BRVO and CRVO, and you can see that 64% of eyes that was out longer than 12 weeks in those that had branch retinal vein occlusions, and those that had CRVOs. 45% of these eyes were getting injections more than 12 weeks. And so I do think that these individuals are definitely doing better. I'm not saying that everyone is going to go to 16 weeks. Everyone is not going to be a home run hitter, but at least if we are decreasing the burden of therapy, I think that we can maximize things. I find in my practice that individuals that get that are getting fatigue of injections, those are the high flyers. Every 4 weeks, 6 weekers. But once they get to 8, 10, and 12 weeks, the burden on their life doesn't appear to be the same. So I think that we've reached a sweet spot if we can deliver injections, 3, 4, maybe no more than 5 times a year in order to keep people on their therapy.
Yeah, and perhaps it goes without saying, this extension specifically for faricimab is not on label, but it is something that we do in practice, and it is something that for our patients benefits them a ton. Getting them out even just a couple weeks at a time gives them so much more flexibility with their family, less anxiety, less time in our offices, more time at work. It makes a huge difference on those barriers. In terms of the safety data for this, in both of these studies, they had great outcomes. Endophthalmitis was very rare. There were no retinal vasculitis events in any of these arms. And it just does show that, whether you start with aflibercept or whether you start with faricimab and move forward, or switch over from aflibercept to faricimab or from any medication to another, the safety profile for these medications is high. So then, the Quasar study is looking at aflibercept 8 milligrams. So this was just recently approved by the FDA for treatment for retinal vein occlusions. And so it's, again, a new tool in our pocket that we get to use with our patients and try to help them overcome these barriers. The way this study worked is that they were randomized either to aflibercept Q4 weeks or aflibercept 8 milligrams every 8 weeks with 3 initial monthly loading doses, or the 8 milligram aflibercept with 5 monthly loading doses. After that, both of these 8 milligram arms went to 8 weeks and Q8 week dosing. And that allowed us to see if this extended regimen after the loading doses allowed for continued improvement in people's visual acuity and retinal outcomes in this population. And so if we look at this slide here, what you see is that in the overall population of all of these RVO patients, it doesn't matter which arm you were in, if you got out to 36 weeks, their visual acuity in terms of their average improvement was very similar. And that to me is very promising. And it doesn't matter whether you're in the BRVO arm or the CRVO arm. I will say, of course, BRVO had slightly better vision outcomes, and that makes sense. But the CRVOs did quite well also.
Absolutely. And we also see the same thing when it comes to the reduction in the OCT. Regardless of the disease, whether it was a BRVO or CRVO, both eyes had a significant reduction in the overall central thickness, and this was maintained through week 36.
Yep. And so now we have the option of using this aflibercept 8 milligrams on label Q8 weeks after they get their initial loading doses of this medication. So that is one of the major burdens our patients are facing. This is proof that you can do this safely and maintain their vision. So I think this data is incredible. If you kind of parse this out and you look at this based on their initial their initial retinal thicknesses, people with thicker retinas did have good vision outcomes as well. They maybe didn't have quite as good vision outcomes as the people who started with lower retinal thicknesses, but it is helpful to know that, regardless of where you start, as long as you start and get these patients into care, you're going to make an impact for them.
And I absolutely agree. I think this goes back to our earlier slides. The one thing I looked at I thought about when we looked at Dr. Howlett's paper is that it appeared that there was a disconnect on when to start therapy. I feel like those that had really good vision, and we know these people have edema, but they probably weren't treated, at least a number of them, and those that had worse vision. I do think that those that have good vision, 30% of those individuals we know will actually improve on their own. But there's also the fact that some will get worse. And so, what's your timeline to switching someone over before they have permanent damage? And then there are also those eyes that present with poor vision that you may be able to, get them from, counting fingers to 2400 if they started therapy. But this here is really strong and data that shows that regardless of how much thickness you have, there was an impact on the overall disease process, is that you were able to thin out the retinas. Not everyone may have had that robust visual improvement, because we know that those eyes that have more swelling typically have worse vision, but there's an impact on the disease state.
Yep. And it gets to a relatively similar outcome in terms of their retinal thicknesses, and they all respond incredibly fast. So, just plugging them in, getting them to trust this process with you can make a big impact. I think this also brings up something else that I wanted to just mention briefly. If I can show my patients that we're following their OCT and I can prove to them that it makes a difference, I think they get more buy-in. And they see this, based on this data, they'll see it very quickly, really after the first 4 weeks. So, as long as we can get these medications into our patients and help them, educate them on what the OCT is, what we're looking at, it helps maintain that level of confidence in the process and hopefully helps ensure compliance too.
Dr. Armstrong, I think you hit the nail on the head. For me, the most important thing that we have in our toolbox is the OCTs and the things that we can show patients. I think that is really important to show them, for adherence's sake, how they're doing, how they're progressing, and also show them when it kind of comes back and what we're really trying to do. It's really important for us, not just to tell patients what they have in their darkest moments, but also share their wins. Show them their photo from when they started, show them their photograph over 6 months or a year, show them where the hemorrhages have gone down, where the dilatation of the vessels have decreased, where the cotton wool spots have decreased. All these things are really important. And I really love the OCTA, particularly for vein occlusions, much more than for my neovascular AMD and my DME patients, because you can actually show the capillary dropout is very obvious in those individuals with vein occlusions. And I tell patients, this is the reason why we need to continue your injections, because these capillaries is really important for keeping the eye dry, are non-existent. They're no longer living despite having really good vision. And this is the reason why I want to keep you on therapy.
Yep. And so if we move forward in these slides, what you see is that a lot of these patients are able to maintain the Q8 week at least interval when we're switched over to the aflibercept 8 milligrams. And so this to me shows that a lot of these patients have a benefit in terms of the decrease on the burdens. And then if you look beyond, some of them even get out to Q12 weeks and maintain that interval too. So a lot of benefit here, a lot of improvement for our patients. And I think that there's a lot to gain in terms of patient compliance. The safety data here is also really good. Again, like really rare events. And I think that it just proves the safety data that we've seen in all the other trials too. In terms of resources and tools, there's a lot that we can really provide our patients, but what do you do in the office? Are there printouts and handouts that you bring? Are there things that you show them or tell them in the office to try to encourage the good compliance?
Absolutely. I think, for all my patients, in particular, all of our new patients, they all go home with some type of information. Either this information is what's already been developed through the American Academy of Ophthalmology or ASRS, or something that our practice have already provided. On those, we make sure that they have a number to call in case there's a change. I think the most important thing for our patients that are getting injections, I want to make sure they understand that although there's very risk to problem with injections, if they have any problems, we want to see them immediately, or at least call the office so we can troubleshoot it. I think the more information you can give individuals, the better. I think that depending on the population that you are addressing, education is an issue, health literacy is an issue. And so understanding why to keep those appointments going forward is important, why the control of your blood pressure of your cholesterol, of your diabetes is critically important. Why you want to make sure you follow up with your general ophthalmologist if you have glaucoma, if you think that may be the only risk factor that they have, because oftentimes these individuals can suffer a vein occlusion in the contralateral eye.
Yeah. And so for me, one of the things I try to do at the beginning is try to educate them on the why. And I spend a lot of time on this, and I try to really plug them into their PCP because I make it a team approach. I give them ownership and say, look, this happened, but we don't have to let it happen again. And the eye is just an extension of the brain and the rest of the body. And so giving them ownership to take control of those risk factors is one of the key things. Also, spending time at the first visit to show them the OCT, explain to them what normal is, hopefully with their contralateral eye, and then show them the difference. I mean, it's striking sometimes the amount of edema you can get in a CRVO or a BRVO. And then to show them 4 weeks later, after our first injection, that it made such a massive impact is hugely rewarding because they feel like they are winning, right? Like you put the power in their hands and then they understand, okay. But then it becomes the challenge, right? Then I have to tell them that it's not over yet. I know we got this fixed, but it's not, we're not at the end. It's a long-term game. Some people need to, the extension trials to prove that if it gets worse again, their vision gets worse, and then you can kind of cut them back. But generally, keeping them plugged in is so important. I do turn to the ASRS. I think they have great handouts. I think it really explains a lot of this really well. And then I even have some patients that want the printout of their Heidelberg thickness data, and they can track it over time and prove to themselves that they're making a better decision by keeping these things on board. So those are just a couple things I do.
And one other thing that I do is that when I send a letter to the referring doctor, I always include the medical physician, and I also send one to the patient's home. I'll let particularly if they're a lady, I'll let them know, hey, you're going to get a love letter from me. And we all kind of joke about it. But clearly, I want them to understand in this letter what's important, because I'll do a summary to the more or less for the medical physician so they can understand things in general terms of really what's going on with the patient, particularly if I think that, their blood pressure is high. We always check blood pressure on these patients. And so sometimes, the blood pressures are high in the office. I'll let them know they're going to follow up. And so sometimes patients don't remember all the things that's going on because it's a really tough day for them. And all they know is that they're going to get an injection and everything else that they really forgotten. But I want them to have that letter so they can also take it to their doctors, because I know that sometimes we send letters, they don't always make it to the respective destinations.
Yeah. And one last thing, just getting back to your patient's experience that we heard about today, asking them about barriers, maybe at the beginning, but really once you get the treatment interval started, because it may not be obvious to them that they don't have the ability to drive afterwards, or they're spending a day in bed because of the irritation. You can try to customize how you do things, whether it's flooding the eye with povidone or just a single drop. You can do things in terms of flushing the eye afterwards and maximizing the time between the time you start numbing the eye and give the injection. So customizing it based on their needs to keep them as comfortable as possible and normalizing the anxiety. Your patient said this so well, everyone has some level of anxiety, even if they don't talk about it. Normalize it and get it out in the open and discuss it. It's a really normal process for them to feel that way, and I don't think anyone wants shots in their eye. They come in and hear this from us, and I'm sure they think we're crazy. But the way I joke about it is that I tell them, we've been doing this all day, but you haven't heard anybody scream from the waiting room. So, there's obviously something right back here. We're doing okay by people, and we promise we're not going to hurt you. So, I think after that, they laugh a little bit, and then they kind of calm down. All right, Dr. Coney. So, thanks to your patience, we have a really good understanding of the barriers to care. And now, thanks to this talk and thanks to all the data that we presented, I think we have a better sense of what's available and how to overcome some of those challenges. And so here are the key takeaways from today's session. First, patients with retinal disease, including retinal vein occlusion, face many barriers to retention and care. And that was really highlighted well by your patients' comments. So thank you for having them. And it's so unique, especially in this program, that we get to hear directly from the patients. And lapses in treatment to RVO result in decline in vision, even though on OCT things can look better. And that really highlights that you need to get these patients in early and treat them without any delay or lapse in care as best as possible. Keep them motivated. Delays in initiation of anti-VEGF treatment for retinal vein occlusion leads to a gain of 4 to 6 fewer letters at 12 months. And that was based on the Bravo trial. And we found that in those patients, even though they eventually got the anti-VEGF and eventually got into treatment, they never really gained the same amount of vision as their colleagues that started anti-VEGF earlier on. And then we heard today about some of the newer anti-VEGF therapies that are available and FDA approved, including the bispecific antibody faricimab, which was approved in 2023, and the 8 milligram aflibercept, which was just approved a couple days ago, which is incredibly exciting that we have it now available in our offices to use. And so to go a little bit more into detail, in the pivotal trial for faricimab for retinal vein occlusion, faricimab at Q4 weeks was non-inferior to 2 milligram aflibercept at Q4 weeks. And in the treat extend phase that began at 24 weeks, which is not approved as of November 2025 and on label, but it is something we can do off label in our offices. Faricimab intervals were extended up to every 16 weeks for many patients and can really overcome some of the barriers of having patients travel in so frequently, needing to come into our offices and see us so often. And in the pivotal trial of the 8 milligram of aflibercept for retinal vein occlusion, the 8 milligram Q8 weeks led to non-inferior visual acuity results compared to 2 milligram of aflibercept Q4 weeks. And this really does prove that you can get these patients to Q8 weeks in many cases. Many of them were able to maintain Q8 week dosing. And what's even more impressive is that now on label, if the Q8 weeks dosing after the loading doses at Q4 aren't enough, you can back up to Q4 weeks for the 8 milligram of aflibercept, and that is on label now. So major changes, amazing results that we got to talk about today, and so excited.
But Dr. Armstrong, listen, I really enjoyed our conversation today. I really hope our audience have learned a few pearls and takeaways in treating those with retinal vein occlusions. And I want to thank you for your time today.
No, thank you, Dr. Coney. Thank you for your expertise, for joining me today, for your patience. It was really great to hear from them and how much they love you.
Thank you.
Dr. Coney and Dr. Armstrong, thank you both so much for being here.
Thanks for having me.
Yeah, thank you so much. This was awesome.
And thank all of you for watching. Please claim credit by clicking on the Claim Credit button on your console. Also, please be on the lookout for our 30-day survey. Your thoughts and comments are important and help us develop future education. We thank you so much for watching and hope to see you next time.